Hi, thanks so much. So my first question for all of you is there anyone in the room who is a professional in healthcare or life sciences? So this is going to be completely out of context. So I'm going to do my best to use human interest stories, anecdotes, anything to bring all of you back to the reality that all of us are patients. All of us end up being caregivers for children and parents and significant others. Healthcare is highly complex, highly challenging, but most important, it is a role that every single human being on earth plays. We all are patients. We all move through life and through death, through grief and through loss and through sickness and in health. And in all of those contexts, we are personally affected, even if our professional lives don't have us focusing on the specific implications for how to fix challenges in healthcare. So I want to unpack a little bit of a big picture view that's familiar with everybody here in this room about the landscape and ecosystem of what we're talking about with Ethereum, both public and enterprise Ethereum. So at ConsenSys Health, I've been highly focused on looking at product market fit in a huge portfolio of products that ConsenSys is building and supporting in the broader ecosystem. What you see here on the left are those products that are presently being integrated to provide platform-level utilities for large healthcare consortia. And I say platform-level and utilities on purpose. So rather than thinking of designing a new automobile, instead we're thinking of needing to build roads that many, many people can design great, great cars for. And so we have all of the components that are necessary and provide a consistent set of services for a huge range of use cases in healthcare and life sciences that supports not just the needs of patients and large-scale enterprises, but a whole burgeoning ecosystem of startups that want to build. So thinking about if you're not in this space, there tends to be a belief, but you are in the blockchain or crypto space, there tends to be a belief that healthcare and life sciences is going to take 15 years before anything major happens, that it's way behind, that it's going to take ages to see traction. And I'm here to tell you that's not the case. Healthcare and life sciences professionals are super conservative. They are very, very risk adverse. They are less likely to be communicating in the ways that the crypto community does their thing. But look at the names on these lists of industry consortia. These are all very large healthcare enterprises that are already under contract, are already pulling capital. Most of them have been building away for at least 2 years, if not 3 or 4 years. So we're talking about large-scale efforts and extraordinary developments in governance processes, rethinking of the basis of competition, what kinds of things happen in healthcare and life sciences that presently all are incorporated into the idea of the nature of the firm, what can be abstracted away, mutualized, federated in common infrastructures that support those enterprises, but also support positive transformation of an industry that desperately needs it. We're honored to work with members of the EU IMI consortium, and that's the Innovation in Medicine Institute. It's a giant public-private partnership between the European Commission and all of the global pharmaceutical companies that you see there listed, and we've got multiple platforms, especially the Enterprise Ethereum Alliance, where I chair the Healthcare Special Interest Group, working on platform views. One thing I would say to the various conversations we've had about interoperability in healthcare and life sciences, cross-chain interoperability at scale, portability of crypto assets, portability of smart contracts, while still a little bit ahead of us technologically from a business and strategy perspective, is absolutely mission critical for our industry. So that's a significant focus area. So what are these giant enterprises actually doing? What kind of things are they working on? So here is an admittedly messy, disorganized laundry list of use cases in the space, and I did that on purpose so that you know. There's not much of a pattern to this. If you're just watching the news and seeing what's going on in healthcare, it's all over the place. And if you're familiar with this industry, it needs to transform, but it's very hard to change. And the reason is because if undue risk is taken, people die. And as a result, you simply cannot be, maverick with novel new technologies without incurring extraordinary liability and risk of human life. Meanwhile, though, there's all kinds of problems in healthcare where people are dying because of unforced medical errors in very large numbers, too. But it's not easy for this industry to change. And it's a multi-stakeholder, complex adaptive system that is deeply broken. It's characterized by incentives that are wildly distorted and counterproductive as well. So it's an absolute it's a match made in heaven for game theoretical models and crypto economic systems that we all see in the future of this field. But how do you actually change it? I mean, the going about of transitioning it is incredibly hard. We started in this market, we started digitizing healthcare about 25 years ago. Back then, healthcare was delivered with paper charts and doctors weren't killing themselves all the time. Now, according to some of the, really resonating one of the earlier talks today about dehumanization, treating people like robots, both doctors and patients, now we have some of our most important people in our healthcare delivery infrastructure that are actively having a suicide epidemic. We have patient experience at all-time lows, even as mobile health and e-health models are coming to pass. So there's a lot of dehumanization that has occurred in parallel to poorly executed automation and unintended consequences and ill-conceived regulations. All of this plays a substantial role. So in my work in this space, I constantly get the question, but what's real in healthcare? Tell me something concrete. I'm skeptical. I don't think we're going to really do anything major. I want to know something that's valuable. And I say to those people, well, geez, out of the 1,500 or so valid use cases that pass all the blockchain and crypto economic filters, the real problem is how would you organize it? How would you transform? And what can be mutualized and federated away from all of the institutions currently describing that care? So I created this PHI readiness framework. PHI is protected health information under the US HIPAA law. And it's a common mental model for us to think about how this industry is going to transform. And essentially, in the now, you've got no PHI use cases getting traction. In the end state, you will have not only PHI use cases, but something I call sensitive PHI, which is not a defined term under the law at all, but it's the difference culturally and socially between the data point about whether I had my annual physical last week or whether I'm HIV positive. These are radically different experiential and cultural processes, and that would be the other extreme. On the y-axis, we've got population health impact. Lots of things going on that can create administrative efficiencies and reduce waste, fraud, and abuse and lower costs, and those are massively important and laudable objectives, but they won't necessarily have anything to do with population health endpoints, like reducing the prevalence and morbidity of diabetes, for example. So what's getting traction right now? Broken into 3 stages of transformation. All of those things that are happening right now follow a common pattern. And I put this pattern together because we need a way to envision this broader transformation of the industry. So there's a huge amount of traction in supply chain, things like directories of provider information that are mostly public, many different interesting aspects of the revenue cycle. And remember, healthcare and fintech and finance are not separate things. Just the Centers of Medicaid and Medicare Services, $3.4 trillion in payments every year. Depending on how you slice the pie, healthcare and life sciences could arguably be the single largest industry in the world. It is the largest budget category of almost every nation on earth. And when you include all of life sciences, that's all of big pharma, all of med tech, all the public sector, all of healthcare delivery, all global health. Think about the billions that Bill and Melinda Gates have dedicated to anti-malaria activities, for example. That's all healthcare. Then when you consider that 60% of health outcomes are attributable to what's called social determinants, that puts us in a situation where the meaning of the context for the delivery of healthcare, what is defined as health data, all of those things are changing. Would you think of an automobile as a medical device? Well, no, not immediately, but it is if it's actually monitoring all your vitals and you have a chronic disease. And there you go. Our entire notion of the quantified self and the contextualization of healthcare, it has completely exploded out of the context in which it was originally built, where you go into a building and you sit in a room and you have paper and the doctor shows up. Now your entire life has higher quality data coming in from wearables than were ever accessible in the past. So stage 3, you have to jump over this chasm of barriers and boundaries. And I'm going to get back to that in just a second. But what is possible if you could get past this chasm? Well, then we could achieve the holy grail of care coordination across organizational boundaries. And most of you have had clinical experiences where you have to see multiple providers and you have to fill out forms 100 times, and you probably found medical errors yourself. When you have complex chronic diseases and the confluence of social determinants, like maybe challenges with access to transportation, poor health literacy, all kinds of things along those lines. Battery. So when you have all those things along those lines, the amount of data that's required and the ability to make it clinically relevant and useful. Can you guys hear me in the back? Yeah. All right, cool. It's not easy. And then precision medicine. Precision medicine is an extraordinary potential that we are not living in at all today. For example, if I were to receive a cancer diagnosis tomorrow, there are all kinds of genetic variants. So I don't blast out of the stratosphere with the mic. If I were to receive a cancer diagnosis tomorrow, there are a whole host of genetic tests that would help match me to different chemotherapies. One chemotherapy might kill me instead of the cancer, and another one might work just fine. Those tests haven't been commercialized, they're not reimbursed by payers, and today, if I were to receive a diagnosis, it's very unlikely that I would receive any kind of precision in the chemotherapy. And many, many people have family and loved ones that die not of cancer, but of treatments. Likewise, this kind of thing plays out in every area of medicine. Precision medicine isn't just about cancer. It's about a wide spectrum of things. Digital therapeutics are a fascinating area worthy of a 2-hour talk on their own. And so why can't we get between these 2 points? We've got all this traction in stage 1. I mean, it's just hundreds and hundreds of active projects. And in stage 3, we have to deal with the compliance, the regulatory uncertainty, privacy risks, wide scope of biomedical ethical challenges. All of those things have to be addressed before we can start computing and transacting with and storing and dealing with health data. And I don't mean storing health data in blocks on a blockchain. Nobody's talking about that. But we're talking about systems that compute and transact and work with health data. And it's healthcare. I mean, really, how far can you get without dealing with health data? Well, the answer is you can do a lot of interesting things in stage 1, and I'm glad we're doing it. But what's really inspiring to me, what's most inspiring, is that we can actually achieve getting to stage 3. So the way strategically that I believe our entire industry is going to transform is to use clinical trials as a bridge between stage 1 and stage 2. And this is for 2 reasons. One, it's because there are 25 blockchain use cases that are a beautiful fit for clinical trials optimization and improvement. It's all over the place, subject of a talk on its own. But secondly, because the way, if you're not in the industry, you may not be aware that the way clinical trials happen is a walled garden, if you will. They happen in mainstream medicine, physically, but they have separate funding sources, separate regulators. Providers become investigators. Patients become research subjects. There's separate ethical oversight that, by the way, improves distinct technology architectures that are specific to a study, which has a distinct protocol and a distinct data model.
This characteristic of the nature of what research is means that right now, in heavily regulated markets like ours and around the world, we can be doing all those things that are in stage 3. We can be doing them now under research protocols, doing them ethically and with high scientific integrity. So bench to bedside is something worth knowing. You might be surprised to know that when a bench scientist, meaning a researcher in a lab, finds some novel molecule or makes some discovery, it can be 17 to 25 years before that is actually translated into standard of practice, standard of care, which means, before it's going to have any population health outcomes. Some of that is based on how long you need to study something in order to have an answer, but not most of it. Huge amounts of the time in that 17 to 25 years are just an inefficient, dysfunctional, broken political system of stages that are required. And in these stages that you see around in this cycle, every single one of them has direct fit with what all of us do that are interested in this space. Totally novel methods for capital formation. We are able to match precision finance to precision medicine. This is radical. In the US alone, $16 billion of private placements every year to early stage pharma and biotech and medtech companies. Every one of those is a candidate for project-specific, unique financing, crowdfunding among patients around the world with a rare disease, or maybe a not rare disease. There are so many different structural options, and if you're in the weeds on this, you know how broken things are now. It's one of the most challenging industries and segments to get funded in the first place. So, and this goes all the way around. So I want to close with a couple of important ideas. We talk a lot about data sovereignty in our space, but I believe we really have reached a cultural tipping point with that. The ability to monetize anonymized health data without the express transaction-specific consent of the original data subject is now culturally and socially being viewed as immoral, and the law is following, and quickly. I predict that practice will be illegal in every jurisdiction in the United States within 24 months. There are already 6 laws in front of state legislatures and other regulations coming from our U.S. federal government defining data blocking or information blocking as an enforceable criminal act if you can't, from a single click, obtain your health data to your mobile phone without complication. So there's all kinds of things happening in the policy and regulatory environment. But everything we need to do in stage 3, all those hyper impactful, incredible, transformative things, they all have certain things that are requirements that underpin all of them. Patient-mediated data exchange, aggregation, and curation underlies every single one of those stage 3 use cases we talked about. Hey, Dan. And so when we think about all of the infrastructures, market functions that we're creating, that isn't about a single use case or a single startup or one pathway. That's the infrastructure for the entire revolution of the system. Of course, we need to revolutionize the Web3 DApp user experience. No question about that. We have a new spoke called Schipul, very, very interesting, that's going to be able to make that near at hand. Self-sovereign ID, not the subject of this talk, but very, very necessary and uniquely complex in healthcare and life sciences. And then finally, the maturing market functions to monetize that data to the benefit of the data subject. So that's it. And thank you very much. Honor to be here.